right. Thank you, Brett. I appreciate it. Um, Let me get this. Excellent. Hello, everyone. Welcome. It's a little something going on my screen.
What do you say?
Says I gotta just say, oh, sorry guys, hold on 1 second.
It looks good on mine.
Okay, perfect. Here we go. All right. Well, welcome everyone.
Play again. That's probably the
Oh, it's probably okay. Let me get that going again. Oh, here we go. There we go. All right. Welcome everyone. My name is Cassim. Thank you, Brett. My name is Cassim. I'm a pain management physician. I work in Eisenhower Desert Orthopedic Center. And today we're going to talk about pain. Now, some of you out there have pain in your neck, in your low back. Sometimes it goes down your arms, your legs. And sometimes this pain limits you from doing the things you want. It could be tennis, golf, or sometimes it limits you from doing your day-to-day activities that you need to do, like cooking and, just walking even. And that's the problem with pain like this. It gets in the way of life, limits what you can do. And we're going to spend some time talking about how we can help those of you out there with pain. We're going to look at three different aspects of pain. We're going to look at the past and talk about how originally we treated conditions like this. And then we're also going to talk about the present, what we do now for pain conditions, and how pain really should be managed in the future. So sit back and enjoy. So the first picture I have up here is a poppy. It's a little flower called the opium poppy. And if you could see this lady, she's making a little incision in that bud. And these trees or these poppy flowers are found all across the Middle East, Afghanistan, and many different countries. If you cut the bud just like she is, a white liquid comes out. And if you leave that liquid overnight, it solidifies. Now, this was originally discovered hundreds of years ago. And the Chinese, even the ancient Egyptians, used to take this substance and notice it had a lot of medicinal properties. Essentially, what they did was they would smoke this, they would eat this, and it would make them very euphoric. Obviously, this is opium, and there were a lot of opium dens across the United States, China, and in many different countries that got very popular. Now, this is an actual picture from Le Petit Journal in 1903, a rendition at least, that shows people smoking this opium poppy. This opium then was used for many different things when people realized what it could really do. It was used in a variety of different types of medicines for pain, for wounds, for injuries. And opium became the best way to control somebody's pain. And if you look here at this slide that I have up, it's a variety of different medications. And obviously the contents are very small, but this essentially has alcohol, opium, and a variety of other drugs that was used for pain. Look at Bell's anti-pain, and that has opium and alcohol, as well as a few other compounds that were used to manage pain. So if we look at the way pain was managed in the past, we would really question the methodology. This is one of my favorite slides. This is from 1800s, not so long ago, and it's cocaine tooth drops for children. We know today that obviously cocaine is not good for many different reasons, especially for children. And so if you look at the way pain was managed back then, there are many different things that were done that in today's standard of care, it's not appropriate. Now, at the same time, there was a physician, James Corning. He was a neurologist, and he developed a interventional technique to help with pain. So they had a lot of different medicines that were using, mainly opium and its derivatives. But in 1884, he took cocaine, which is also a very powerful anesthetic, and he injected it in a medical student, unfortunately, a volunteer, one of his in his spine, and he noticed that it got rid of sensation below the waist. This was the invention of the epidural injection. This injection since then has transformed medicine. It's been used for delivering babies, as well as we use it for pain, a variety of different pain conditions, spinal pain mainly. Another key discovery that came around this time in the past was by a guy called Röntgen. He was a German physicist. He won the Nobel Prize in Physics in 1901. He discovered rays that he called X-rays. X because he didn't know what they were. This is believed to be the very first X-ray ever taken of his wife's hand. That's her ring. Unfortunately, they didn't know the dangers of X-rays and that it was radiation, caused a lot of problems. However, this was another breakthrough technology that allowed people to look beyond the skin and flesh. And actually in the early 1900s, if you go to buy some shoes, people would have X-ray boxes. You put your feet in there, take an X-ray of your foot, and that's how they would size your shoes. Obviously, we don't do that today because of the dangers with X-rays. Now, World War I, 1914 to 1918, and then World War II, 1939 to 1945, revolutionized human history. There was a lot of death, destruction, injuries at a rate that people had never seen. So the need for pain management became extremely important. And at this time, fortunately, people leaned back towards a very special type of treatment. This was something that came by a small pharmaceutical company back then called Merck. In 1827, they had gone to those opium poppies. They knew that opium helped people get euphoric and get rid of pain. And they looked for the most powerful compound, or more the active compound in the and they called it morphine, after the Greek god of dreams. Morphine was the first opiate. It transformed the way pain was handled. Especially during the First World War and Second World War, they figured that they have a solution. Every soldier received an ampule of morphine. Whenever they were in pain, they would take some morphine, it would help them. And if their injuries were very severe, they would take a lot of morphine and slowly drift away painlessly to sleep. This, they believed, was finally the solution to pain. So if you look at the way medicine was practiced in the past, things that we think of as very negative, cocaine, heroin, opium, and morphine, those were the treatments. Another very revolutionary change that took place at this time was the development of the field of anesthesia. They used morphine, X-rays, and epidural injections, as well as a lot of different types of gases to put people to sleep, allowing them to perform longer and complex procedures. So if you look at the past, many things came about in the past that we use today. We've had to refine them, improve on them. Don't use cocaine in the medical field, at least, for pain management. So the past gave us a lot of different tools that we had to refine in today's world. So if we look at the present, the success of morphine in the First and Second World War created a floodgates of pharmaceutical companies who created many different derivatives: Vicodin, Percocet, Norco, Dilaudid, methadone, fentanyl patches, many different ways of taking these opiates. All these synthetic opiates flooded the market. And the theory was that if you're in pain, take one of these. And if that didn't work, take more of this medicine. And this became the treatment plan in the 1960s, 70s, and even the 1980s for pain. People tried to create stronger and stronger opiates, and diamorphine came out. And this was really the first time people realized, okay, maybe there's a problem, because diamorphine became heroin. Um, Essentially, heroin is a opiate that caused a lot of problems. People started wondering if opiates were really the solution they thought they were. Many medical journals published articles about opiates and increasing deaths. And also there was a concern that these opiates had many other problems. And in the present day today, we've realized that opiates may not be the solution. For one thing, these opiates, all these pain medications, the Vicodin, Percocet, oxycodone, Dilaudid, if you take it for an extended period of time, you develop dependence, meaning your body needs these medicines. You can't stop these medicines, or you will go into withdrawal, which is a multitude of symptoms: sweating, diarrhea, runny nose, abdominal pain. Tolerance is another property, meaning if you take these medicines for a long period of time, your body gets used to it, and you need more and more and more, which results in a lot of side effects. And these side effects can be significant as well, including constipation, leading to bowel rupture, changes in memory, personality, and many other changes as well as you go up on the doses. Now, some people are even breaking rules to get these medicines, and that's abuse. Addiction was another big problem where people, were really hooked on these medicines. They overused them and they broke rules to get the medicines. And we started seeing diversion as well with these opiates, which was a situation where people would pretend to have pain to get these medicines and sell them. And finally, something called opiate-induced hyperalgesia. This was a newer finding where we realized the higher doses of medicines you took, the more opiates you took, the worse your pain actually becomes. As you can see, there are a lot of different problems with opiates, and all the treatment strategies used in the past with these medicines, and even the modern day, were not very helpful. So what's next? Well, thanks to the invention of X-rays and precision-guided injection treatments, we were able to do treatments exactly the areas we had problems, meaning use a machine like that. And as you can see, that's an X-ray machine. We call it a C-arm because we can move it around in different directions. And there's a patient laying on the table with a blue drape on her back. We're going to use this X-ray machine to get medicine to very specific areas in the back. That way, rather than using oral medicines that go through your stomach and your liver and goes to your whole body, we can put medicines precisely where we need to. And this is how precision medicine developed, precision interventional treatment. This is a picture of an epidural injection. You can see a little line on the side of your screen that's going to next to a nerve. That's the L or lumbar 5 nerve. The dye, which is black, outlines the nerve, and you can go very close to the nerve within millimeters and put cortisone, which is an anti-inflammatory steroid. You can put lidocaine, anesthetic, but the cortisone really reduces the inflammation in that area. This is another precision treatment. You see a little black line there, and that's going into a joint in the spine, which is called the facet joint. Facet joints are little joints in your back that can have arthritis. And by putting medicine in that, you can reduce inflammation. This is another treatment for arthritis in a joint in your low back. It's called the sacroiliac joint. You can see a little wire connected to a needle and a black outline within the joint that shows us we're in the right place, and then we put some cortisone in it. Also, with the precision-guided treatments, X-rays, and our ability to deliver medicine in specific areas, we went beyond treating just the epidural space. This is a lumbar sympathetic block. The line is a needle going to the very front of the vertebral bodies. In the very front of the vertebral bodies, you have a whole group of what we call ganglia. These are little relay stations. And by blocking these ganglia, we can prevent symptoms like phantom pain, phantom syndrome of the leg. So somebody has an amputation and they still have pain in the foot. We can help with that. We can help people with migraines and also conditions where you have swelling in your arms due to pain, something called complex regional pain syndrome. So as you can see in the present, we learned a lot about how to deliver medicines to specific areas. We realized that general treatment with opiates is not the best. And also we started realizing that we need a team of people to help with pain. But still people suffer. Even though we have all these different treatments today, over 100 million people in the US suffer with chronic pain, costs over $550 billion a year from treatments, people calling in sick, ER medicine, and not to mention those of you who out there with pain and are suffering, can't do what you want, can't live the life you want. So pain, even today, with all the different treatment options we have, continues to be a problem. So what do we do? Where do we go from here? So the future management of pain is actually here today. And the best way to help those with pain is really with a comprehensive approach, meaning medications such as opiates if needed, but also other medicines like anti-inflammatories, nerve pain medicines. Muscle work is very important. So when you reduce pain, let's strengthen the muscles around the core, around the spine. So physical therapy, appropriate chiropractic, targeted therapy. That's the precision guided treatments where you can deliver medicine into specific areas of the spine, of the shoulder, of the knee with needles under X-ray, ultrasound, or CT guidance. So you use a different tool to see where the medicine is actually going. And behavioral treatments, because when people are in pain, it affects the way you feel. Suffering certainly changes people's personalities, changes what they like to do. So we do need to address that. And even alternative treatments have options, has a place in treating pain. Now, some alternative treatments have a lot of evidence, such as acupuncture, but some do not. And here is where it gets a little tricky. There are a lot of products out there on TV, on the newspapers that market treatments without any evidence. And that's a little bit deceiving because, you know, the companies are trying to take advantage of people who are in a bad place. So definitely the alternative therapies have a very powerful role in treating people, but needs to be done cautiously. As you can see, there are many different ways of helping those in pain. And this really is the comprehensive model that works best when it comes to managing pain. And finally, the final evolution of this comprehensive pain model is a pain center. Pretty much what that means is when we're treating people with pain coming from the spine or spinal pain, injections, therapy, alternative medicines, behavioral therapy, medications, all these different things, as well as targeted treatments can help. But sometimes we need to talk to surgeons, we need to talk to neurologists, rheumatologists, and having all these people in one setting really helps with communication, with understanding of each other, and that really provides the best treatment options for patients. For instance, here in Eisenhower Desert Orthopedic Center, we work under the umbrella of a spine center, meaning we work with spine surgeons, physical therapists. So the spine surgeons know how the interventional pain doctors like myself can help, what we can do. And we know when we need their help to do surgical treatments to get the best outcomes. So when we talk about the comprehensive treatment plan and pain management, there really is many different options. There really are many different treatment options, and there really is a lot of hope for all of those out there, all of you out there with pain. But in addition to the spine centers or the pain centers and the comprehensive treatment models, a lot of newer treatments are evolving. And it's evolving really based on science. So let's look at what happens and how pain is communicated in your body. So here's an individual getting a needle stick on the finger. Okay, and if you watch this video, we see the needle go through the finger. There's a little blood, but there's a lot that's going on underneath. Pain is sensed by free nerve endings. They have their own nerves called nociceptors. Nociceptors are specifically designed to sense noxious or bad or painful, unpleasant stimulation. So if you touch a hot pot, these free nerve endings, nociceptors are triggered and you pull your hand away. But what happens if you keep these nociceptors or pain receptors active for a long period of time? Like a chronic illness, arthritis, degenerative disc disease, spondylosis in the spine. Well, you have a lot more pain fibers that fire. So the pain signals travel all along the peripheral nerves, and as they get closer and closer to the spine, they group together and they enter the spinal canal into the posterior or the back of the spine, which is known as the dorsal horn. So this signal travels from that back, that spot right there, all the way across to a special track or special route called the spinothalamic tract. Now, as pain travels from the periphery, and we look at people and we're doing these precision guided treatments, we need to realize that there is a big difference between acute and chronic pain. Like I said, those nociceptors, when they fire and you touch a hot pot, that's a quick firing of these nociceptors. You pull your hand away, they stop firing. But if they're being forced to fire for a long period of time with degenerative disc disease, arthritis, those nociceptors keep signals going to the spinal cord and that spinal thalamic tract, and it really changes that track. And after about 3 to 6 months, you develop many other features of pain, where things that were not painful become painful. You become hypersensitive, and slowly things start changing in your life. And that's when we start developing chronic pain syndrome, we call it. Obviously here, when we're doing precision guided treatments, we've got x-rays and ultrasounds and different ways of treating people. And here's a physician performing the ultrasound and x-ray guided procedure, but also aware of how to manage the chronic pain syndrome from a very basic pathophysiological view, which is what we just looked at. Steroid or cortisone into somebody's shoulder. The little probe used there is an ultrasound. And using the ultrasound, you actually visualize the medicine going into that spot. This lady down here is using a treatment for spasticity, where the muscles just lock up. It's a machine called an EMG, electromyography, where they use the sound of the spastic muscles to put Botox to loosen them up. And so I'm showing you a variety of different aspects of guided treatments, where we're looking at things and getting very specific. And also in the future, spinal cord stimulation is going to be, and is currently is, one of the best ways to control spinal pain. Here, using an x-ray machine, a needle is placed and two wires are put in your back. Those two wires prevent the pain signal going to the brain. If you remember the video we just watched, all the pain signals travel to the back of the spine. Then it goes to that pain tract that goes from whichever part of your body to your brain. These wires block that, and we can control many different types of pain. And there are lots of different types of spinal cord stimulators coming out. Many different companies are producing different speeds, different frequencies, and all these different types of treatments affect pain in a different way. This is one of the other types of spinal stimulators, which is called a DRG, or dorsal root ganglion stimulator. As you can see, the picture on the right is one of the original spinal cord stimulators, while the one on the left is a DRG, or dorsal root ganglion stimulator. These devices have been called the pacemakers for pain. And again, burst stimulation is a different type of spinal cord stimulation as well. So neuromodulation of spinal cord stimulation is certainly moving into the future with different techniques to help people when their pain's worse when they're laying down, standing, or lying face down. So it's accounting for positional changes as well. In addition to the spinal cord stimulation, there's another treatment called the intrathecal pain pump. This is another way of using opiates, which we know have a lot of problems. But if you put this opiate right in the spinal fluid, what people found was you need a very low dose and a lot less to no side effects. The pain pump, however, you do carry opiates with you, and you need gradual changes of that pain pump. These are another newer treatments that have revolutionized pain. We can burn nerves around joints. For instance, if you have pain in your spine from arthritis, you really can't do a joint replacement there because the joints are very small. But you can go around the joint and get rid of the pain nerves. It doesn't affect your sensation. It doesn't affect your ability to walk or move because we avoid those nerves. It just gets rid of that pain nerve, which is sitting there like an appendix in your stomach and only causes problems, no good. So we'll get rid of them. This is just another picture of that ablation procedure we were talking about, where they're burning some nerves around the facet joints, or the little arthritic joints in the back. Also, a lot of publicity and growth of a treatment called platelet-rich plasma, or PRP. This has been used in many, many different types of pain. It's also being used in the cosmetic field. Pretty much what we do is we take your own blood, then we spin your blood. When we spin your blood, there are different weights in your blood. Your blood consists of red blood cells, platelets, and white blood cells, pretty much. So the platelets, that's a part of your blood that signals to the rest of your body to heal you. For instance, if you cut your hand and starts bleeding, platelets rush to their area, and it releases these molecules called interleukins that tell the rest of your body to send healing agents there. So by taking this platelet-rich plasma, we can inject it into torn muscles, into arthritic joints, epidural spaces, multiple areas, and try to get your body to heal it. And we've had good success with that. Obviously, we do this with guidance and try to heal certain parts of your body. Stem cell therapy is also another very popular and controversial treatment. Some people love stem cell therapy. Pretty much the idea is cells, meaning you can take your fat tissue or you can take bone marrow of your own body and take cells that can morph or change into the area we're injecting. Controversy is in the way we harvest or get these cells and how we deliver these cells. This is getting very popular, though. A lot of people are using them with there's no written studies showing a lot of proof, but definitely widely used type of treatment in terms of stem cell therapy. So we've come a long way from the past opium dens to smoking opium to the present, where we used opiates and many different treatments in isolation, to a future where there's a lot of hope in new technology, hope in people working together as a team to find solutions for patients, and hope to reduce suffering and improve people's quality of lives. Thank you very much for your time. Learn from the past, live in the present, and believe in the future. Thank you.
All right. Fantastic, Dr. Cassim. Thank you.
Thank you.
At this time, we're open for Q&A. So a lot of different things in there about pain and different stuff. So feel free to unmute yourself, excuse me, and ask a question of the doctor, and let's start a vibrant conversation here. Who'd like to go first? It's a quiet crowd. So Dr. Cassim, I said, maybe we'll start with a question. Is like, so for someone who has and is experiencing pain in whatever realm of their body, how do they access knowledge about knowing how to get into care, the stream? How does it work?
So, pain is very common, and usually people with pain either, talk to their primary care physician, or, if it's very severe, go to the emergency room where they can give you some options. Watch out for online stuff. Some of it is good. Some of it is obviously questionable. But certainly, Eisenhower Desert Orthopedic Center has a lot of resources for you online, which you can look at through the Eisenhower Medical Center website and the Eisenhower Desert Orthopedic website as well. And you can access some information, some knowledge about what's going on. And then based on the region or location of pain, there are specialists for these different areas. And we'll get you to the right people and hopefully reduce some of these symptoms for you.
Great. Kind of a follow-up question to that is, how do you personally work with our surgeon side of the business, if you will, and then you have our physical therapy side, we have our sports medicine side. Everybody comes to it with a different kind of perspective, but how do you and pain management work with the different aspects of where you're at in that cycle?
Where one person alone is not going to solve the problems. So usually, physical therapy is the basis. I mean, strengthening muscles is key for most or any pain condition. So usually the pain management doctor kind of uses all these different specialties to help after we have a diagnosis. So the first step is to really figure out what's going on. And that's where, we have imaging all the way from x-rays to MRIs to CT scans. We have diagnostic tests like EMGs, and all these different tools with examining patients and listening to patients that gives us an idea of what's the problem, what's causing your pain. And once we have that figured out, the interventional docs, like the pain management guys, we can deliver medicines to specific areas. For instance, if it's a pinched nerve causing sciatica, we see that in an MRI. We can do an epidural, and we can use X-ray machines, deliver the cortisone to that area, reduces the inflammation. But that's not enough. So we get the physical therapist involved to strengthen the muscles. And sometimes we get imaging and we see that the spine's fine. So the pain, even though it looks like a sciatica, is not. So that's when we get maybe some of our sports medicine doctors involved. They can use ultrasound, look at the muscle, and try to figure out if there's a nerve trapped outside of the spine. And in the very end, if we do injections and we confirm our diagnosis, we know it's coming from the spine, but the therapy and the injections are not powerful enough because the condition or the pinching, the stenosis of the nerve is severe, then we get our surgeons in. And even the surgical field, they have a lot of new treatments and a lot of minimally invasive strategies that can really help give long lasting benefit with pain.
All right. Additional questions from people? I know, Dr. Cassim, you work for somebody who is, and we've done a lot of orthopedic lectures in the last month, but those who are contemplating surgery or moving in that regard for consultation and that, how does a pain management specialist like your area work with these patients pre, during, and post surgical?
Absolutely. So again, pain management with the spine surgery or even joint surgery, the key is to figure out the problem, right? So we get the imaging. For instance, let's take spine problem. Let's say somebody has sciatica. Images will show many different things. Many pinched nerves can be present in somebody's back, but they all don't cause problems. So by putting cortisone in the specific areas that we believe is causing individual pain based on exam and based on, what patients tell us, we help surgeons have a better outcome. So usually if you go to a surgeon, they will send patients to us to get injections to help isolate the problem so that the surgical treatment is really minimized and also get great outcomes. Sometimes people have this negative stigma about surgery, but surgery really can make a huge difference, especially with spine or joint problems. People used to, stay away from joint replacement, but it has been an amazing tool to really help those suffering and don't have any other options. Some people do well with, cortisone injections, high ligand injections, epidurals. But if you have a work, for instance, if somebody has arthritis in the knee and they're bone on bone, injections are not going to help that much. And physical therapy will help, but not as much. Surgery, on the other hand, has evolved to the point where it can make dramatic changes in people's lives. Same thing with the spine. If you're getting an epidural injection, every 3 months, but it lasts only for a week, you're not really helping yourself. A small little surgery, depending on what you have, maybe a laminectomy, or even, if it's a disc, a little disc removal, a discectomy, microdiscectomy can really be a long-term definitive solution for pain. And we work with our surgeons who know what we can do and we know what they can do, and we really use each other's expertise to get the best outcomes for patients.
Fantastic. All right, who has a question other than me? Please feel free to unmute. I thought I saw somebody. There we go.
I have a question. Can you hear me?
Yes, we can. Go ahead.
Okay, yeah, I couldn't figure out how to get on this. Anyway, I've had 4 major back surgeries. I am fused from L2 through S1, so 8 screws and 2 rods in my back. I'm still having a tremendous amount of pain, especially my sciatic nerves when I'm sitting, like driving. Would you think that an epidural would help that?
Thank you for the question. So again, I need to obviously review your records and see what's going on.
Right.
look at you. But in general, for a situation like that, if you've been fused, that's a significant fusion, meaning they
Right.
have fused all the nerves that really cause sciatic pain. So we want to make sure that it's not a muscle like the piriformis muscle that can cause spasms of the sciatic nerve after it leaves the spine. We also want to see if you need maybe something a little bit more than an epidural. Sometimes epidurals do help in this situation. Something called a caudal injection, where we put it in, put the medicine really low down and send it all the way through, could help. But typically for something like this, the pacemaker we spoke about, the spinal cord stimulator, is the best real option. And that works very well for people who have had surgery and still have your symptoms. Obviously, you want to do therapy and medicines and the whole comprehensive picture with it.
And for the person who was just chatting, I had to mute you. Everybody was there's a lot of reverb, so that's why we mute you. But feel free to unmute and follow up with a question or ask another question. Anyone with a question out there for the doctor? It's a quiet crowd. There we go.
Yeah.
Go ahead. Janet, do you have a question?
No, I too am having an issue with how to do this, but I think everything was pretty clear, as it could be. So yeah, we're good.
Thank you.
All right. Other questions from anyone? I know the key here is, as the doctor mentioned, is, if you have questions in regards to pain, and you have that, is to reach out to Desert Orthopedic Center, get a consult, talk with a physician, a nurse practitioner, basically come in and review you individually. That is the key here. Not everybody is the same, and so you're unique, and they will work with you directly. It looks like we have another person who unmuted. Do you have a question?
Who's saying?
Paul?
Yes.
Go ahead.
I've had a fusion of L4-5 just 2 years ago, and actually was very successful. I was took a good year of pain before I got to that point of having the fusion. But for the past 9 months, I've been in extraordinary pain on my right leg, all the way from my hip to the knee. And so I've been talking with an orthopedic surgeon, and I've also had a cortisone in the hip joint, my right hip joint, and that has reduced the major pain that I live with on a day-to-day basis. But I still can't do things like walk and stand for any amount of time. So my bigger question from all of that is, not knowing exactly where this pain is coming from at this point, is whom do I speak to about this? Back to my my back surgeon, the spinal surgeon? Do I look somewhere else for a neurosurgeon or some kind of therapy, physical therapy? I'm at a loss, and my PCP hasn't been very helpful in answering that question yet.
Sure. Well, sorry to hear that you're in pain for so long. And obviously, that's a long time to be in pain. And some of the problem with pain like this is exactly what you said. It's hard to figure out where it's coming from. Now, you've had a fusion in your back, and the way you're describing your pain, it could be coming from your low back, but also you told me that the injection in your hip helped you. So those injections, since we use X-rays or ultrasound or however you had it, is usually with some kind of guidance.
Yes.
So if they injected the medicine right in the hip joint and it helped you, that tells us that the hip joint is most likely your pain causing element. If it didn't last long, it tells us that maybe the hip joint has a problem that's a little too much or too severe for the injection alone to help.
Mhm.
So this is when, I mean, we would get you in and really get some imaging of your hip, get imaging of your back, see which one's worse, identify, where exactly your symptoms are and try to match it to the low back or the hip joint, and then go to the next step, which could be, therapy and medicines, or maybe even surgery. I know surgery is not something we jump into, but if you've been living with this for 9 months, that's just 9 months of suffering you don't want.
Right.
So I guess the question is, one, are you still doing therapy? Are you doing injections? Are you trying to figure out the source of the problem? And the key is not to just keep doing the same thing again and again, but to move on to really the definitive treatment. I mean, fix the problem, so to speak.
Well, that's correct. It's figuring out where it's really coming from.
So did the hip injection help you a lot?
It took away the pain that I lived with daily, so that I'm not in pain except when I'm mobile and when I'm walking for any period of time. If I'm standing for 5 or 10 minutes, things like that, where I'm looking at it. It's times when I'm standing there, I'm putting pressure on my pelvis and my hip and my knee, my leg. So that's when I get the pain. So there's something in there that, whether it's coming from the hip or whether it's coming from my back or whether it's some other muscular issue.
It sounds like a hip joint. I mean, again, I need to look at your stuff and figure things out, but it could be a hip joint, or it could be both too. I mean, but if it's your hip joint and that got a lot better, how long has it been since you had the injection?
Just 1 month.
And has your pain gone down and remains down by 50-60%?
Yes, it has.
So that tells me that definitely the hip joint was a problem. So you might have a secondary problem going on in your back.
Yeah.
You probably need an MRI of your back to see if you have nerves that correspond to that area impacted as well. Have you had an epidural in your back or anything like that?
I'm sorry?
Have you had an epidural injection in your back or anything?
No, not since the surgery 2 years ago.
Yeah. So, I mean, I would get into, you can even come see one of us in the orthopedic group and get some imaging, see what's going on, and figure out the next steps.
Yes. Okay, great. Well, thank you very much. Appreciate your thoughts.
Happy to help.
Right. Great questions. Next question.
Yeah, I have a question.
Go ahead.
First of all, doctor, how do we get to you or get to your office for a consult? I've tried to make a couple of calls in the last week, and we've got a long hold and a callback promise, and haven't got any of it. So
Yeah.
just kind of stuck right now.
Right. And I'm sorry about that. We are experiencing a very high call volume, and we've been actually working on this actively. We get something like I just had a meeting about this recently, but something over 1,000 calls a day or some big number. If you have MyChart Messenger, that's a nice way to get a hold of us. You could send it to your primary care doctor and request a consult to Desert Orthopedic. If you have an Eisenhower physician, or I mean, if anybody has access to the Epic system, they'll be able to send us a message directly. Or you could even, do you have a primary care doctor that's with Eisenhower?
They're not in the Eisenhower system, but they're here in Palm Desert, and they communicate with Eisenhower.
Perfect. They should be able to get in touch with us. Just tell them to send me a message on our computer system, which is Epic. Or if they call us or send us a consult, we'll be able to get things moving and get you in. And I'm sorry about the delay. It's been a little technological issue that we're working on in terms of the volume of people that are trying to call us, and we're trying to fix that.
Thank you.
My pleasure.
All right. Great questions. Who else has a question? Anyone out there? I know we're getting close to the end of the time, but if you have a question and you would like to ask, please feel free to do so. Give it one more second. All right. Well, as Dr. Cassim said, and I'll reiterate, our call volumes across all areas, not just as orthopedic, across our call centers, every single aspect, and that is also throughout the valley. It's not just Eisenhower; it's other hospitals and other medical groups. Our staffing is. We're trying to ramp up staffing. We're trying to get calls back. It is a priority for management, and it's on a daily call. He's on many, I'm on many calls, and it is the top of the list on almost every single call we have to try to get faster turns and get people into the care they need. That said, you can always continue. As I said, the squeaky wheel gets a response. You never know when you're going to get the person who actually picks up the line and does whatever. So don't hesitate to just leave a message. Feel free to leave a couple messages if need be, and elevate that. And then this is, as I mentioned, being recorded. And so this will be edited over the next 5 to 7 days. And then I will email it out to anyone who registered. It will be sent to you via the email you registered on. And then I will also have it in our YouTube channel. And all of our past lectures and everything going back 2 to 3 years easily, if not longer, and plus podcasts are on our YouTube Eisenhower Health YouTube channel. And then also, when you go to our eisenhowerhealth.org website, you go to Desert Orthopedic and you'll see the lectures in there as well. So a multitude of areas where you can look at this in more detail. And then, as Dr. Cassim said, use my chart, use Epic, make sure that you're connecting through your primary care physician or whoever your physician is that's handling your majority of your care to get them in to get you the appointment you need. Dr. Cassim, any final words from you, sir?
No, thank you. Thank you all for being here. Thank you very much, Brett. Great job as always. Pleasure seeing you, working with you. Thank you.
Absolutely. All right, everyone. Well, happy early St. Patrick's Day on Friday. None of us wore green because it doesn't show well on video. So otherwise we'd be a floating head, as I've done in the past, which is kind of fun, but not the right look. So have a great week. Stay healthy, and please reach out as you need us. All right. Have a good evening, everyone.
Thank you.